Welcome back to ACCEL for September 2014. I'm Alfred Beauvais. Disc 3 begins with a discussion Ray Gibbons had with Dr. Paul Poirier, Director of Rehabilitation and Prevention at the Quebec Heart and Lung Institute in Sainte-Foy, Quebec, Canada. They cover primary and secondary prevention for patients with diabetes. An update.
Welcome to ACCEL, Paul.
Thank you very much.
Paul has a very interesting practice. He has prior training in the management of diabetics and diabetes, and his practice actually includes patients without overt cardiac disease who come to his center and his practice in a variety of ways, but before they've had a cardiac event. So, Paul, can you tell us a bit about those patients and how they get into your practice?
Yeah, those patients are usually, the first symptom they complain about is short of breath. So the family physician send us to the rehab center to get a kind of cardiology screening for silent heart disease or for heart failure, for example, because of this shortness of breath. So they can be short of breath because of heart disease, but they also can be short of breath because they're out of shape. You know what? They got type 2 diabetes, so they're not that well trained in terms of physically being active.
Yeah. So often get sent to you for evaluation. Are there very many people in your practice who would have had, for example, CT, coronary angiography, or coronary calcium scores to get to you? Does that kind of testing go on in Canada?
No, it's not that obvious. I mean, in Canada, the practice is different from US, so we don't go imaging that fast. Usually we do follow the usual old practice way, so treadmill testing, physical exam first. So you look for a S4 because of left ventricular diastolic dysfunction, because of diabetes per se, or because of hypertension. And you go for silent ischemia or screening like treadmill testing. Imaging, even if it fits in the guideline, we don't do the first thing.
So those patients who don't have overt disease, obviously we want to manage their blood pressure, we want to manage their lipids, but I learned in talking to you that you actually also manage their oral hypoglycemics and their insulin therapy. Is that right?
Yeah, I do. It's kind of a old knowledge that I've got from my internal medicine that I keep on doing. The only thing I don't do is insulin pump. So it keeps me away of the game in terms of practicing with diabetes patient, because there's a lot of new agent coming in, and aside from being hypoglycemic agent, we hopefully want those agents to be safe and saves life also.
I know that there are some large cardiology practices in the U.S. who have one or more members of their group who are interested in that, but it's certainly not the norm. How hard or easy do you think it would be for a cardiologist with prior training, perhaps 5, 10, 15 years ago in internal medicine, to take on the management of the diabetes portion of these patients?
So I don't think it will be that difficult, because remember, in the good old days of cholesterol management, cardiologists were not there before 4S, right? Endocrine and internists were there, and they were using those very funny drugs with all those side effects. And then cardiologists move into that field and use statin all over the place. It may be the same with the weight management drugs, right? So they use the weight management, the internists and endocrine use those drugs for weight loss. Most of those drugs were banned from the market afterwards, but still cardiologists are not taking over. I think it's the same with diabetes. So diabetes have been treated by internists, GPs, and endocrine. But if you got safe drugs without any or less hypoglycemic event, those safe drugs can be managed pretty easily by cardiologists.
Just to give our audience a sense, do you go to sort of CME programs on diabetes and hypoglycemics?
Because of my training doing the rehab and prevention cardiology, I covered the obesity, exercise, diabetes, and cardiology meetings. So I go to ADA every year. So that's how I keep up.
Okay, well, I think that's important for the audience to understand. That would certainly be a challenge in many practices. We've been talking about sort of what I would label as primary prevention. Let's move on to the issue of secondary prevention. That is, diabetics who have had an infarct or have had a revascularization procedure. They're, I think, an ongoing challenge from all of the available data in the U.S. How are things going in Canada with respect to managing?
It's the same. I mean, the management is pretty disappointing from a point of view of reaching goals for blood sugar, for blood pressure, and for cholesterol. I mean, we know where we should go, but the thing is, we're not there. If you look at NAIMS, only 20% of patients were at goal for those three risk factors, which are blood sugar in terms of glycated hemoglobin, blood pressure, and cholesterol. So we're not good. And the thing is, even if we're doing better, because there was a big decrease in the last 40 years in terms of CVD event in those patients still have twofold risk. They do worse after coronary syndrome. They do worse after...
So they, in principle, have more to gain from proper secondary prevention than the non-diabetic.
Yeah, they're more to gain. And this residual risk, is it due to diabetes per se? And that's why drug company want to try to have this wonderful drug that take care of the diabetes and take care of the cardiovascular event too. Because you can have a sugar that affect your eyes without affecting your brain, without affecting your heart, without affecting your kidney. So if you can have a drug that take care of everything from a diabetes point of view and from a cardiovascular point of view, this is a blockbuster.
So do you have any tips for our listeners in terms of your program about how you proceed to better control blood pressure and lipids in your diabetic patients? Because that's a challenge, I think, for everybody.
It's funny because usually diabetes patients are sedentary. Their BMI is high. You don't become diabetes because you're physically active and you eat the right thing, right? So you need to be pretty persuasive to those guys that they're responsible for their health. First, they have to take their drugs. Every day I see patients, I take a blue one, I take a yellow one, and I take a red one. They don't know what their drugs are for. And they've been taking those drugs for 10 years. So they need to be responsible for their drugs, for their health. And then they understand it's all behavior. Not all behavior, but mostly behavior. And cardiologists, we're not there. I don't think we're good in behavior medicine. So we need to work as a team to take care of those patients. Because if you don't work as a team, you will tackle one thing at a time as a silos.
So from the team approach, do you have nurses or nutritionists? Who are involved in your program for the
nurses,
team?
Psychologists, kinesiologists, anybody that could help the patient. And usually those are better than us because we're not trained into behavior science.
So a traditional approach that most of us associate with cardiovascular rehab, you're actually using to manage risk factors in your diabetic patients.
Exactly.
And that would seem to be pretty similar to what was done in the COURAGE trial and the Barry 2D trial that were very successful.
You need to be as complete as possible to tackle everything because there's so many things going on that you need to tackle.
So I think the take-home messages for our listeners are obviously diabetics are a particular challenge. Some of them will get into your practice by various routes without having cardiac events, so they'll be primary prevention patients. And at least in your practice, you're managing their oral hypoglycemics, but you're also trained and going to CME programs to stay on top of that field. And in the secondary prevention world, use a team approach similar to traditional cardiac rehab programs and similar to what was used in the COURAGE and Barry 2D trials. Does that summarize it?
Yeah, exactly right.
All right. Well, thanks for coming to ACCEL, Paul.
Thank you.